Today we're going to talk about respiratory distress syndrome. The definition for respiratory distress syndrome is a breathing disorder that affects the newborns. RDS rarely occurs in full-term infants. The disorder is more common in premature infants born about 6 weeks or more before their due dates. We're going to see a video that is going to explain us.
And I am going to make a short video about acute respiratory distress syndrome, otherwise known as ARDS. Now, acute respiratory distress syndrome is a disease of lung inflammation, and the inflammation leads to a cascade of events that leads to lung injury. Now, there are a number of different things. The lungs are very prone to injury for a number of reasons, and I'm going to get at that as we talk through this video. Now, the lung inflammation is really centered around the nexus between the capillaries and the alveoli and the thin membrane in between. So this is really a syndrome of inflammation of the pulmonary alveoli and capillaries. Now, it can be caused by a number of things. So, causes or predisposing events. One possible cause is that there is injury to the alveoli. Now, it could be injured by chemicals, like smoke inhalation. It could be caused by severe burns to the tissue if the person was in a fire and breathed in hot gases. It can be caused by infection, where we have little bacteria and a buildup of pus with injury to the alveolar epithelium. Or it can be caused by the inflammation can start in the capillary side. Now,
the etiology. The main cause of respiratory distress syndrome is a lack of surfactant in the lungs. The surfactant is a liquid that coats the inside of the lungs. A fetus lungs start making surfactant during the third trimester of pregnancy. This helps keep the lungs open so breathing can occur after birth. Without enough surfactant, the lungs will likely collapse when the infant exhales. The infant then has to work harder to breathe. He or she might not be able to get enough oxygen to support the body's organs. Some full-term infants develop RDS because they have faulty genes that affect how their bodies make surfactant.
Welcome to USMLEFasttrack.com. The section we're going to talk about today is from First Aid for the USMLE Step 1, 2013 edition.
Page 555. What is neonatal respiratory distress syndrome? Neonatal respiratory distress syndrome is a syndrome in premature infants caused by developmental insufficiency of surfactant production and structural immaturity in the lungs. So basically, in this condition, there is surfactant deficiency, and as we mentioned, surfactant is what decreases the surface tension. So if you have surfactant deficiency, there is going to be an increase in the surface tension, which is going to lead to increased work for breathing, and therefore leading to alveolar collapse.
Signs and symptoms. Signs and symptoms of RDS usually occur at birth or within the first few hours that follow. They include rapid, shallow breathing, short pulling in the chest below and between the ribs with each breath, current sounds, flaring of the nostrils. The infant also may have pauses in breathing that last for a few seconds. This condition is called apnea.
So you're getting about 90 breaths, and so now he has a VSD and an ASD and a little pulmonary stenosis, I guess. But he's been sick, coughing, no fever, like you said, right? But he's been coughing and he had a period of apnea. Is that right? He just stopped breathing on Monday, and someone had to blow in his face. Is that right?
He got choked off of that, whatever he's coughing.
Okay. But he's only had like what, 2 ounces today, he said?
That's all.
Yeah.
When he started coughing, he turned blue.
How is respiratory distress syndrome diagnosed? The tests include chest X-ray, blood tests. Blood tests are used to see whether an infant has enough oxygen in his or her blood. Blood tests also can help find out whether an infection is causing the infant's breathing problems, and an echocardiography.
Is an X-ray of a premature baby born at 32 weeks of gestation, grunting after 4 hours of birth, X-ray taken on day 1, query RDS or respiratory distress syndrome. Respiratory distress syndrome in premature babies is a common problem. In mature births, a chemical called surfactant keeps alveoli open so that they easily fill with air and work efficiently. Surfactant is made by type 2 pneumocyte cells of lungs, and lungs do not start making surfactant until later in pregnancy. So premature babies cannot keep their alveoli open as full-term babies do. Such babies have to work very hard to meet their oxygen requirement. The condition is known as respiratory distress syndrome or RDS. The symptoms are difficulty in breathing, cyanosed, which is bluish color of skin, flaring of nostrils, rapid breathing, which is known as tachypnea, grunting sound of breathing, and chest retractions, which is pull of ribs and sternum inside during breathing. There are two major complications of RDS. One is pneumothorax, which means air in the pleural cavity, pressure on lungs from baby's own efforts to breathe, or from the artificial breathing machine, which is known as ventilator, can cause lungs to rupture, which causes air to leak into pleural cavity. This air causes lung to collapse. The other complication is intraventricular hemorrhage, which is bleeding into the ventricles of the brain. So X-ray taken on day 1 does not show much to an inexperienced eye, but experienced radiologist would argue that there is a slight haziness of lungs to suggest RDS. There is an NG tube, nasogastric tube, in position. The tube is inserted from nose, passes through the esophagus and goes into the stomach, mainly for feeding purpose. So
Treatment: surfactant replacement therapy, breathing support, oxygen therapy, other treatments such as antibiotics, supportive therapy, treatment for patent ductus arterius.
See the graphs. Details. Pressure, pressure. Let's see the instruments. Surfactant. Cursor, sir. Here. This is a feeding tube, appropriate size feeding tube. This is 2 ml syringe, which is required. And properly working bag and mask. The procedure. So first of all, we clear the airway. I've already prepared the surfactant. This is a mark. Pushing surfactant now. Followed by bagging. Slowly Now let's see the graphs and the vitals. Let's see the vitals also. Let's see the vital graph. 1 second. Let's see the pressure. Are you ready to repeat the procedure second time?
The diagnosis for
What
RDA.
diagnostic test is indicative of neonatal respiratory distress syndrome? A diagnostic test indicative of neonatal respiratory distress syndrome is lecithin sphingomyelin ratio of under 1.5 in the amniotic fluid. So if it is under 1.5, this is predictive of neonatal respiratory distress syndrome, where if it is over 2, this means that the lungs have fully matured. What are some complications that can arise due to neonatal respiratory distress syndrome? We already mentioned that neonatal respiratory distress syndrome can lead to alveolar collapse, but because there is a persistent low oxygen tension, there is a risk of patent ductus arteriosus. Now to understand this, we mentioned in the cardiology chapter that you need high oxygen tension after birth to close that PDA. So when you don't have that in neonatal respiratory distress syndrome, it will keep the ductus arteriosus open. Now to correct the low oxygen tension, if you are to give supplementation of oxygen, this can lead to too much oxygen in the neonate, and that could lead to additional problems such as retinopathy of prematurity and bronchopulmonary dysplasia.
to USMLEFasttrack.com. The section we're going to talk about today is from First Aid for the USMLE Step 1, 2013 edition.
Page 556. What is acute respiratory distress syndrome? Acute respiratory distress syndrome is a life-threatening lung condition that prevents enough oxygen from getting to the lungs and into the bloodstream. What are all the causes that can lead to acute respiratory distress syndrome? Acute respiratory distress syndrome can be caused by trauma, sepsis, shock, gastric aspiration, uremia, acute pancreatitis, or amniotic fluid embolism. Describe the pathogenesis of acute respiratory distress syndrome. In acute respiratory distress syndrome, one of the causes that we just mentioned is going to cause diffuse alveolar damage and increase in alveolar capillary permeability. Now, when there is an increase in the alveolar capillary permeability, there is going to be a leakage of protein-rich material along with neutrophilic substances into the alveoli. This protein-rich material is going to cause the formation of the intra-alveolar hyaline membrane, and the neutrophilic substance is going to cause damage to the alveolar wall. So basically, in acute respiratory distress syndrome, there's going to be high amounts of fluid that will end up getting into the alveoli and cause damage there.
For more information on this topic,
proning an RDS patient receiving invasive mechanical ventilation in the ICU must be done carefully to ensure safety during the procedure. For the procedure to be successful, it is vital to use trained and experienced staff. The video you are about to watch shows the technique used to achieve the prone position and the return to the supine position. The procedure usually requires 3 to 4 people. One person remains at the head of the bed to secure the endotracheal tube and the ventilator lines. This person coordinates the procedure. The other people position themselves on each side of the bed. The procedure is performed following 5 steps. The first step is to prepare the procedure. At this stage, you have to decide which direction to turn the patient, to the left or to the right. Priority is given to whichever side the central venous lines are located. Check the length of the vascular lines and the transcutaneous saturation cable to be sure they are long enough. Move the ventilator as close to the patient as possible. Check the patient's hemodynamic status and the level of sedation. Secure the endotracheal tube and the gastric tube. Protect the skin on the forehead, knees, iliac crests, and thorax from pressure sores using adhesive pads. Protect the patient's eyes and get the electrocardiogram electrodes ready for use. The second step is to move the patient horizontally. Then they are moved towards the opposite side. From the side they will subsequently be turned towards laterally by pulling the bedsheet. The patient should be moved towards the side of the central venous line. After moving the patient sideways, the hand on whichever side they will be rotated onto is placed under the buttock. A new bedsheet is also prepared along the length of the bed. The third step is the side lie. The patient is rotated laterally in a full side lying position. The patient is maintained in this position for a short time while one person removes the electrodes from the anterior thorax and another person attaches the new electrodes to the back. The fourth step is complete proning. The new bedsheet is used to pull the patient and to move them into the final complete prone position. The body is placed in a horizontal position at 180 degrees. The abdomen is usually not supported. The upper limbs are placed alongside the body. The fifth step is post-proning installation. The patient is moved to the center of the bed. The head is turned laterally and moved every 2 hours. The endotracheal tube must be easily accessible. Care should be taken to close the eyelids tightly and avoid ear tinting.
That was the prime positioning in severe acute respiratory distress syndrome. Thank you for watching the video. Bye.